Welcome. If you're listening, you want to get up to speed on key health topics quickly and reliably.
That's right.
You've pointed us towards some serious material today, chapters from Rutherford's Vascular Surgery on Acute Deep Venous Thrombosis, or DVT.
Heavy stuff, but important.
So our mission is to really dig into the key stuff from these expert sources, give you the crucial insights on DVT without you needing a medical degree.
Exactly. We're focusing on how common DVT is, the epidemiology, and what usually happens after someone gets it, its natural history.
And why is that so critical?
Well, because VTE, that's venous thromboembolism, which includes DVT and pulmonary embolism, or PE, it's a major preventable cause of death in hospitals. The Surgeon General even issued a call to action about it.
Preventable being the key word there.
Absolutely. And it causes long-term health issues, too. So think of today as getting the lay of the land, understanding the scale of the problem and how it tends to play out.
Okay, let's start with the scale then. How common is this, really? Give us the big picture.
The numbers are, well, pretty substantial. In the U.S. alone, we're looking at estimates of over 900,000 cases of VTE each year. That includes new clots and recurrent ones.
900,000.
And to get a bit more specific, there's a long-running study from Olmsted County, Minnesota.
Right.
They found an average annual rate of about 122 VTE cases for every 100,000 people.
Okay, 122 per 100K. How does that break down between DVT and PE?
It was roughly 56 for DVT and 66 for pulmonary embolism per 100,000 people. So, it's definitely not some rare condition. It affects a lot of folks every year.
And does it affect everyone equally? Are there differences between groups?
Good question. That same Olmsted County study showed slightly higher rates in men compared to women after adjusting for age.
Interesting.
And race seems to play a role, too, in the U.S. at least. White individuals generally have lower VTE rates than African Americans.
Lower than African American?
Yes, but higher rates compared to Hispanic and Asian or Pacific Islander populations.
So there are some definite demographic differences.
There are. And remember, this isn't just a U.S. thing. It's global. Estimates from the European Union show hundreds of thousands of DVT and PE cases annually.
And a significant number of deaths linked to them.
That's right. A considerable number of fatalities. It really underlines that VTE is a worldwide health challenge.
You mentioned earlier the numbers can change depending on who you're studying. Can you elaborate on that? How much variation are we talking about?
Oh, it varies hugely. Depends on the population, obviously, but also things like how intensely they screen for clots, whether preventative measures like blood thinners are used.
Right, the prophylaxis.
Exactly. And even the accuracy of the diagnostic tests matters.
Give us an example of that variation.
Okay, take patients with acute spinal cord injuries. If you systematically screen them using venography, that's a specific X-ray for veins, the rate of DVT is incredibly high, around 81%.
81%? Wow.
Yeah. Now compare that to, say, patients in the ICU. If they get thromboprophylaxis, those preventative blood thinners, the DVT rate is reported between maybe 10% and 18%.
Or slower.
Right. But if they don't get that preventative treatment, the rate jumps up to 25% to 32%.
That really shows how much prevention helps in those high-risk situations.
It absolutely does.
Immobility seems like a common thread there, right? Spinal injuries, ICU stays?
Precisely. And here's something quite telling. A lot of VTEs in critically ill patients aren't actually picked up while they're in the ICU.
Oh, when are they found?
Often after they've been discharged.
Really? Why is that?
Well, it suggests that the extended period of being less mobile, even after the critical phase, might be a major trigger.
So the effect lingers.
It seems so. We also see higher VTE rates in nursing home residents, again, likely linked to reduced mobility over long periods. It looks like the longer you're significantly inactive, the higher the risk climbs.
Okay, so it's definitely a spectrum of risk depending on the group.
Exactly. If you generalize, medical surgical ICU patients seem to have a lower DVT risk than, say, those with spinal cord injuries, major trauma, or neurosurgery patients.
Lower than those groups.
Yeah. Their risk looks more similar to people after major orthopedic surgery, like a hip or knee replacement.
But still higher than general patients on the wards.
Generally higher than the average medical surgical ward patient, yes. And interestingly, one study found really high DVT rates in critically ill trauma patients very early on, like within the first week.
Even with preventative treatment?
Even with prophylaxis, yes. It suggests the initial massive trauma itself creates a huge immediate risk that's maybe hard to counteract completely right away.
That makes sense. What about infections? We've all been thinking more about viruses lately. Do they play a role?
That's a really relevant point now. Research has shown a definite increased risk of VTE with severe viral infections in critically ill patients.
Like which ones?
Well, H1N1 influenza, for example. Patients with severe H1N1 had a much higher rate of both PE and DVT compared to other ICU patients.
Wow.
And what was interesting there was that moderate intensity treatment with heparin, the blood thinner, seemed to offer significant protection in that specific H1N1 group.
And what about COVID-19?
Early data suggested a similar elevated VTE risk with COVID-19, and again, potential benefits from using heparin preventatively.
But we're still figuring out the details.
Yeah, the exact best type of heparin, the optimal dose,
Yep.
that's still being worked out. But it clearly shows how these big systemic infections can tip the body's balance towards forming clots.
And how interventions like heparin might help tip it back.
Precisely.
Okay, so we've got a handle on how common DVT is and who tends to get it. Let's shift to why. What are the main risk factors driving this?
We often talk about two broad categories. There's secondary or provoked DVT, which happens when there's a known trigger or risk factor present.
Okay.
And then there's primary or unprovoked DVT, sometimes called idiopathic, which occurs seemingly out of the blue without an obvious reason.
But you're saying the focus is shifting.
Yeah, the emphasis now is maybe less on those strict labels and more on just identifying any contributing factors, especially those we might be able to change or reverse.
And we're getting better at spotting those risks.
Definitely in hospitalized patients. Thanks to better objective tests and lots of studies on preventative treatments, we can identify high-risk individuals in the hospital setting much more effectively now.
What about people who get DVT outside the hospital as outpatients?
That can be a bit trickier to pin down sometimes. But some key risk factors stand out for outpatients.
Such as?
Things like having cancer malignancy or having had surgery or major trauma within the last 3 months. Those are significant.
Are those different from the risks for hospitalized patients?
Well, surgery and malignancy are common risk factors in hospitalized patients too, of course.
Mm-hmm.
But the overall mix of contributing factors can sometimes differ between inpatients and outpatients.
Okay.
We know that roughly half, maybe 47% of outpatients who get a DVT have at least one known risk factor.
And does having more than one risk factor matter?
Hugely. The risk really adds up. The more factors you have, the greater the likelihood of developing a VTE. It strongly suggests DVT often results from a sort of combination punch, underlying vulnerabilities plus triggering events.
How do doctors actually assess this cumulative risk? Are there tools for that?
Yes, there are scoring systems. The Caprini score is probably the most widely used, especially for surgical patients.
How does it work?
It assigns points based on various known risk factors, age, type of surgery, history of clots, mobility, things like that, to give an overall risk estimate.
And for non-surgical patients?
There are other scores like the Padua score or the Improve score used more for medical patients.
Are these scores highly accurate?
They're helpful, but they have limitations. Their ability to perfectly predict who will actually get a VTE is moderate at best.
Why is that?
Probably because DVT development is just really complex. There are lots of interactions between factors, and these scores can't capture every single nuance perfectly.
Okay, let's break down some of those individual risk factors. Age seems like an obvious starting point.
It is. It's a really strong and consistent risk factor. Study after study shows DVT incidence climbs steadily if people get older.
How much of an increase are we talking?
Well, it's very rare in young children, but it becomes much more common in people over 80. One study showed something like a 30-fold increase between folks in their 30s and those over 80.
30 times? That's huge.
It is. Another found the prevalence of clots in men went from about 0.5% at age 50 up to nearly 4% by age 80. Age is definitely a major player.
What is it about getting older that increases the risk so much?
It's likely a mix of things. As we age, we tend to collect more of the other known risk factors, maybe less mobility, more medical conditions.
Right.
Plus, it seems that the threshold needed to trigger a clot might actually decrease with age. Your body might just be more susceptible.
Is there a biological reason for that?
There's evidence suggesting an age-related shift towards a more prothrombotic state. Older individuals often have higher levels of certain markers in their blood that indicate the clotting system is more active. And physical changes in the leg veins, maybe increased blood pooling or stasis around the vein valves, could also contribute as we age.
You said DVT is rare in young children.
Generally, yes. VTE is uncommon in kids. However, we are recognizing more cases, especially in hospitalized children.
And when it does happen in children, is there usually a reason?
Almost always. It's nearly always linked to identifiable risk factors and often multiple ones simultaneously.
Like what kind of factors?
Things like being immobilized, having inherited conditions that make blood clot easier, thrombophilias, maybe oral contraceptive use in teens, limb weakness, or having central venous catheters, especially in the leg veins.
And if a child gets a DVT outside the hospital?
That's often linked to having had a previous DVT or having an underlying thrombophilia.
Okay, let's move to another big one. Immobility.
Yes, definitely a major contributor. Not moving for extended periods is a well-known risk.
How does that work?
Normally, when you walk, your calf muscles squeeze the veins and pump blood back up towards your heart.
The calf muscle pump?
Exactly. When you're inactive, that pump isn't working effectively. Blood flow slows down, especially in the lower legs and around those vein valves. That stagnation increases the chance of a clot forming.
Is there direct evidence for this?
Oh, yes. Autopsy studies have clearly shown the longer someone was on bed rest, the more likely they were to have a DVT.
Even before surgery?
Even being immobile before an operation has been linked to doubling the risk of getting a DVT after the surgery.
Wow.
And think about stroke patients. DVT is way more common in their paralyzed limbs.
Makes sense.
And people with neurological conditions causing limb weakness or paralysis. They have about a 3-fold higher risk of DVT and PE, and that seems to be independent of just being hospitalized. The lack of muscle activity itself is a problem.
What about travel? We hear about economy class syndrome. Is that a real thing?
Prolonged travel, especially sitting cramped for hours, does seem to be linked to a slightly increased VTE risk. There are documented cases of PE after long flights.
But it's hard to study.
It is tricky to pin down the exact prevalence compared to the general population, and often travelers have other risk factors too, which complicates things.
So is there any solid evidence?
There is growing evidence. Case control studies comparing people with clots to those without have found long-distance travel increases DVT risk.
Really?
Yeah, one study even suggested a 10% risk of developing a calf DVT on long flights if travelers didn't wear compression stockings.
10%? That's not insignificant.
No, it suggests it's more than just anecdotal.
So should everyone worry about long flights?
For most healthy people, the absolute risk is probably still quite small. But it seems to be amplified in people who already have other VTE risk factors.
Like what?
Research showed travelers with things like a prior history of clots, recent injury, varicose veins, obesity, not moving much during the flight, or heart disease had a significantly higher DVT risk during travel.
So it's a combination again.
Very much so. The WHO consensus is basically that there's likely a small association between air travel and DVT, mostly affecting those with pre-existing risks.
And maybe other types of long travel too.
Potentially, yes. Similar links might exist for long car or train journeys. Even, believe it or not, spaceflight have been linked to thrombosis.
Spaceflight. Okay, that's niche. Let's talk about having had a previous clot. That seems like a strong predictor.
It's a major one. Somewhere between 23% and 26% of patients diagnosed with the new DVT have had one before.
And what's the risk of it happening again?
Recurrence is common. Depending on age and sex, studies show it happens in about 2% to 9% of cases, but that figure climbs much higher over longer periods.
Does it matter why they had the first clot?
Yes. The risk of recurrence is notably higher if the first DVT was unprovoked, meaning no clear trigger was identified.
Why would that be?
It often suggests an underlying tendency for the blood to clot more easily, maybe an inherited thrombophilia or an acquired condition that wasn't initially obvious. That underlying issue makes recurrence more likely.
We often hear about factor V Leiden. Is that linked to recurrence?
That's an interesting one. Factor V Leiden is a common genetic variation that definitely increases the risk of a first VTE event quite significantly.
But not recurrence.
Surprisingly, no. It doesn't seem to have a major impact on the risk of having a second clot after the first one.
So it helps explain the first event, but not necessarily predict the next one.
Exactly. Other inherited conditions, like the prothrombin gene mutation or deficiencies in natural anticoagulants, like protein C, protein S, or antithrombin, do increase the overall risk, including recurrence.
And acquired conditions.
Yes, things like antiphospholipid antibody syndrome or malignancy also increase the risk.
Let's talk more about malignancy or cancer. That comes up a lot with DVT.
Absolutely. It's a very strong link. About 20%, 1 in 5 of all first-time VTE events are associated with an underlying cancer.
1 in 5.
Yes. And people with diagnosed cancer have roughly a four-fold higher risk of developing a DVT or PE compared to people without cancer.
And sadly, PE can be fatal in cancer patients.
Yes, unfortunately, PE is a significant cause of death for cancer patients.
Can a DVT sometimes be the first sign of cancer?
It can. In a concerning number of cases where someone presents with an apparently unprovoked or idiopathic VTE, an underlying cancer is discovered later on, sometimes within the next year or two.
Are certain cancers more linked to DVT than others?
Yes, the risk is particularly high with cancers of the pancreas, kidney, ovary, lung, and stomach. An unprovoked clot should definitely prompt consideration of underlying malignancy.
Why does cancer increase clotting risk so much? What's the mechanism?
It's really multifactorial, lots of things going on. There can be physical effects like a tumor pressing on a vein.
Obstructing flow.
Right. But also major biological changes. Cancer can increase platelet counts. Patients might be less mobile. They often have central venous lines.
Treatments play a role too?
Yes. Chemotherapy and radiation can contribute. But fundamentally, the cancer cells themselves can release substances, things like cytokines and tissue factor, that directly activate the body's clotting system.
So the cancer itself makes the blood sticky.
In a way, yes. It can create a prothrombotic state. Cancer can also affect the blood vessel lining and impair the body's natural systems for breaking down clots. It's a complex interplay.
Okay, another well-known trigger, surgery?
Indeed. Surgery isn't just one level of risk, it's a whole spectrum.
Depends on the surgery.
Exactly. It depends on the patient's own risk factors, the type of procedure, how extensive it is, how long it takes, and also how much immobilization happens afterwards.
Are some surgeries higher risk than others?
Historically, yes. Things like hip fracture repair, total hip replacement, total knee replacement. Those major orthopedic surgeries have traditionally carried higher DVT rates compared to less invasive procedures.
When do these post-op clots typically form?
It's interesting, about half of them seem to develop during the operation itself.
Really? In the OR?
Seems so. The other half typically form in the first, say, 3 to 5 days after surgery.
Does the risk end when the patient leaves the hospital?
Not necessarily. It's really important to remember the risk of DVT can extend well beyond the hospital stay.
And having had surgery before increases risk for future surgeries.
Significantly, yes. A history of previous surgery is a strong risk factor for developing DVT after another operation.
How does surgery actually cause clots? Is it Virchow's triad again?
Pretty much. You often get all three elements in surgical patients.
Yeah.
Slowed blood flow from immobility, potential injury to the vein walls during the procedure, and changes in the blood making it more likely to clot.
How does the blood change?
Surgery itself can trigger a temporary hypercoagulable state, likely from the release of tissue factor during tissue handling. Different types of surgery seem to vary in how much they trigger this.
And the body's ability to break down clots?
That can also be temporarily suppressed after surgery. It's sometimes called the postoperative fibrinolytic shutdown.
Are there other post-op complications that increase DVT risk?
Yes, things like having a heart attack after surgery, needing a blood transfusion, or developing a urinary tract infection. Those have all been linked to a higher risk of subsequent VTE.
What about major trauma, like a serious accident? Similar risks to surgery.
Very similar, and often even higher risk. Trauma patients are definitely a major concern for DVT.
How high can the rates be?
Autopsy studies on trauma casualties have found DVT rates as high as 65%.
65%. That's astonishing.
It is. Now, screening studies using ultrasound usually find lower rates, partly because we use preventative measures now, and ultrasound might miss some asymptomatic clots.
But the risk is still elevated.
Oh, definitely. Recent major trauma significantly increases DVT risk, and certain groups are especially vulnerable.
Who are they?
Older patients, those needing transfusions or surgery for their injuries, people with leg fractures, femur or tibia or spinal cord injuries,
Factor.
longer hospital stays, the overall severity of the trauma, pelvic fractures, direct injury to veins, having lines in the femoral vein, and just prolonged immobility all add to the risk.
Is the underlying mechanism similar to post-surgical DVT?
Largely, yes, immobility, potential vessel injury, and a hypercoagulable state. After major trauma, the body can sometimes use up its natural anticoagulants and clot-busting components, leading to that prothrombotic state.
Okay, let's switch gears slightly. Pregnancy. That's a unique state. Does it affect DVT risk?
It does, significantly. Pregnant women have a VTE incidence that's estimated to be 6 to 10 times higher than non-pregnant women of the same age.
6 to 10 times higher.
Yes, and sadly, VTE is a major contributor to maternal deaths.
Is the risk higher at certain times during pregnancy or after?
The risk seems to be even higher in the postpartum period after delivery, especially after a C-section.
But during pregnancy itself,
When clots are objectively documented during pregnancy, they seem to happen pretty evenly across all 3 trimesters. The risk is elevated throughout.
why is the risk so much higher in pregnancy?
It's a combination of things again. Mechanically, the growing uterus can press on the big veins in the pelvis, slowing blood return, particularly from the left leg. That's why DVTs are more common in the left leg during pregnancy.
And biologically?
Pregnancy naturally shifts the body's clotting system towards being more prothrombotic. Levels of several clotting factors go up. There's also a decreased sensitivity to one natural anticoagulant, and levels of another, protein S, are lower.
What about breaking down clots?
The fibrinolytic system, the clot breakdown system, is also altered during pregnancy.
Is there a link with inherited clotting disorders?
Yes, a significant percentage of women who get a VTE during pregnancy turn out to have an underlying inherited thrombophilia. That's why testing is often recommended if there's a personal or family history of clots.
Are there other factors that increase risk around childbirth?
Yes, things like older maternal age, using medication to suppress lactation, high blood pressure during pregnancy, and needing assisted delivery methods like forceps or vacuum can also increase the risk of DVT after delivery.
What about hormones people take, like birth control pills or hormone replacement therapy, HRT?
That link is very well established, especially for oral contraceptives containing estrogen.
How strong is the link?
Studies consistently show significantly increased odds of thrombosis in women using them. It's estimated that maybe 25% of seemingly unexplained VTE events in women of childbearing age could be linked to oral contraceptive use.
Does the risk go away after stopping?
Yes, the risk seems to decrease relatively quickly after stopping the pills, and it doesn't seem related to how long someone used them.
Does combining them with other risk factors matter?
Definitely. The risk is higher if combined with things like surgery or having an underlying thrombophilia, especially factor V Leiden.
Factor V Leiden again.
Yes, there seems to be a synergistic effect there. Some newer types of oral contraceptives might also interact more strongly with factor V Leiden.
And what about HRT after menopause?
Similar story. Estrogen-containing therapies used for HRT, but also for things like lactation suppression or treating prostate cancer, are also linked to increased VTE risk,
When is the risk highest with HRT?
often in the first year of use.
And the mechanism? Is it changing the clotting balance?
Likely, yes. These hormonal therapies can affect levels of clotting factors, natural anticoagulants, platelet function, and the fibrinolytic system, potentially pushing things towards a more prothrombotic state.
This might sound strange, but can blood type affect risk?
It's not strange at all. There actually does seem to be a connection.
Really? Which types?
Studies have found a higher prevalence of blood type A and a lower prevalence of type O in people who've had a VTE.
Interesting. Is that consistent?
It seems particularly noticeable in younger women using oral contraceptives or during pregnancy. We know blood type influences levels of things like von Willebrand factor, which is involved in clotting, and it tends to be lower in type O individuals.
So it's a subtle factor, but real?
Exactly. Not a major driver on its own, but it seems to play a role in the background.
What about where people live or their ethnicity? Does that make a difference?
There do seem to be geographic variations. For instance, some older studies noted higher rates of post-op DVT in Europe compared to North America.
Even within the U.S.?
There have been reports suggesting higher rates in central U.S. regions versus coastal areas.
And ethnicity?
Autopsy studies hinted at differences, maybe similar rates in Black and white Americans, but higher than in Ugandan blacks, or big differences between places like Boston and Japan.
But those could be due to other things, right?
Absolutely. Differences in healthcare, how often prophylaxis is used, diagnostic methods, those are all potential confounders.
So could it be genetics or environment?
It's quite possible. Both could play a role. This idea is supported by the fact that the prevalence of certain inherited clotting conditions, like factor V Leiden, also varies geographically.
Okay, a couple of specific conditions. Inflammatory bowel disease, like Crohn's or ulcerative colitis.
Yes, VTE is a known complication there. It affects somewhere between, say, 1% and 7% of IBD patients.
When does it usually happen?
Often in younger patients, usually when their disease is active, and sometimes clots form in unusual places.
Is it linked to inherited factors?
Mostly not, it seems. It's thought that the active inflammation itself may be related to endotoxins activating immune cells, could be promoting the clots.
And lupus. Systemic lupus erythematosus.
SLE also carries an increased risk, particularly for patients who have specific antibodies called antiphospholipid
Big
antibodies.
lupus anticoagulant.
Exactly. Lupus anticoagulant or anticardiolipin antibodies. Patients with SLE who have these antibodies have a significantly higher risk of both venous and arterial thrombosis.
What about varicose veins? Are they a definite risk factor?
They're often listed, yeah. Sometimes they might just be a marker of previous vein problems.
But is the evidence strong?
It's a bit inconsistent. In hospitalized patients with other big risk factors, varicose veins don't always stand out as an independent risk factor after things like surgery or stroke.
What about in otherwise healthy people?
Some researchers have questioned their importance there, especially in younger women. However, other studies have found them to be independent predictors, potentially more strongly linked in younger patients.
Any other links?
Well, having had superficial vein thrombosis, a clot in a surface vein does seem to increase the risk for a later GVT or PE. And a big recent study confirmed varicose veins increase DVT risk, though maybe not PE risk as much. So the connection is there, but maybe nuanced.
We've covered a lot of acquired risks. What about anatomical factors someone might be born with? You mentioned iliac vein compression earlier.
Right. Sometimes the body's plumbing itself creates a risk. Iliac vein compression, often called May-Thurner syndrome, is a key example.
That's the left iliac vein being squashed.
Yes, typically by the right iliac artery crossing over it in the pelvis. This narrowing can impede blood flow and make clots more likely, usually in the left leg.
Who tends to get this?
It's seen more often in young to middle-aged women, especially after multiple pregnancies. It can show up as sudden left leg pain and swelling, or as chronic venous problems that don't respond well to usual treatments.
Is it common?
Anatomical compression itself might be quite common. Postmortem studies and modern imaging show some degree of compression in many people without symptoms, but symptomatic compression causing swelling or DVT is less common.
Is there anything else like that? Popliteal vein entrapment?
Yes, that's another less common anatomical issue where the popliteal vein behind the knee gets squeezed.
What causes that?
Often unusual anatomy of the calf muscles, the gastrocnemius heads, sometimes bony growths or thick fascia. Interestingly, while artery entrapment there is more common in men, vein entrapment seems more frequent in women.
How does it present?
Usually in young adults, maybe with signs of chronic venous insufficiency or an actual DVT.
Yeah.
Also, if someone has an aneurysm, a bulge in their popliteal vein, that carries a high risk of DVT and PE, and repair is usually recommended.
Okay, last couple of traditional risk factors. Obesity and heart disease. How solid is the evidence there?
It's actually remains somewhat equivocal, surprisingly.
Really? Obesity isn't a clear risk factor.
Some studies link higher BMI to increased VTE risk, especially in postmenopausal women, and it is seen as a risk factor for recurrent DVT. But it hasn't consistently emerged as an independent risk factor in all major studies, like the Olmsted County one or specifically after stroke.
What about heart disease, like heart failure?
Well, certainly severely ill medical patients, including those with heart failure or after a heart attack, are at high risk, often due to immobility and the general severity of their illness.
But is the heart failure itself an independent driver?
The evidence for that is conflicting. It's hard to disentangle the effect of the heart condition itself from the general state of being critically ill or immobile. Thromboembolism is definitely a major cause of death in untreated heart failure, though.
So overall, severely ill patients are high risk, but isolating the specific contribution of heart disease is tricky.
That seemed to be the conclusion. The overall illness severity is a major factor.
Okay, we have covered a massive amount on who gets DVT and why. Let's shift now to what happens after someone develops a DVT. What's the natural history?
Right. Once a clot forms, a few things can happen. The body tries to organize it, heal around it. It also tries to break it down. That's thrombolysis.
Can the clot get worse?
It can. It might grow, extend further up the vein that's propagation, or another clot can form nearby rethrombosis.
What are the most important outcomes clinically?
From a patient's perspective, probably the two most critical things are recanalization, the vein reopening, and the risk of having another clot, a recurrent VTE.
Let's start with recanalization. Does the vein usually open up again completely?
Early studies using older tech suggested blood flow often improved over time. More modern ultrasound studies give us a better view.
And what do they show?
They show recanalization does happen in most patients after an acute DVT, but it's variable.
How quickly?
Some reopening often starts fairly early. The biggest reduction in clot size usually happens in the first 3 months or so.
Does it disappear completely?
Complete resolution has been seen in some patients by maybe 9 months, but the whole process can actually continue slowly for months or even years. It's not always a fast or total fix.
Okay, so it often improves, but might not fully resolve. What about the risk of getting another clot, recurrence?
That risk is unfortunately quite significant. Data suggests nearly 30% of patients will have another VTE within 10 years.
1 in 3 within a decade. That's high.
It is. And interestingly, recurrences often follow the pattern of the first event. So if you had a PE first, you're more likely to have another PE than a DVT next time.
Are there factors that predict recurrence?
Yes, independent predictors include older age, obesity, underlying cancer, and persistent limb weakness or paresis.
Does treatment affect recurrence?
Oh, absolutely.
Yeah.
Older trials clearly showed much higher recurrence rates with lower doses of heparin compared to standard anticoagulation.
Does follow-up imaging tell us more?
Yes, serial ultrasound studies suggest those older trials might have even underestimated the true rate of new thrombotic events. We see new clots in the other leg, existing clots growing, and rethrombosis in the original leg.
Do these happen at different times?
Yes, there seem to be different time patterns for these various types of recurrent events after the initial DVT.
Lastly, the really serious outcome, mortality. What's the risk of death associated with DVT and PE?
Long-term autopsy studies going back decades painted a stark picture. They found PE in about 26% of hospitalized patients who died.
26%.
Yes, and in about 9% of those cases, the PE was considered fatal, the cause of death.
What does that translate to annually?
If you extrapolate, it suggests something like 1% of all hospitalized patients experience a PE each year, and maybe 0.36% of all hospitalized patients die from a PE annually.
That really puts the seriousness into perspective.
It absolutely does. It underlines why understanding VTE, preventing it, and treating it effectively is so incredibly important.
This has been incredibly informative, a real deep dive. So to quickly recap the key points, DVT is common, it's a serious health issue, and it's driven by a huge complex web of risk factors: age, immobility, surgery, cancer, genetics, hormones, the list goes on.
That's a good summary. And while the body often works to clear the clot through recanalization, it's not always complete.
And the risk of it happening again is substantial.
Exactly, which really underscores the need for good prevention and management strategies based on understanding these factors.
Understanding who's at risk, what contributes, and the likely course is fundamental for doctors trying to prevent, diagnose, and treat this effectively.
Couldn't agree more. And the insights we've shared today come straight from leading experts in the field, giving you a solid foundation based on reliable sources.
So, to leave you with something to think about, we've discussed this vast number of risk factors for DVT, many overlapping and interacting. Given that complexity, what do you think are the most effective, maybe the most impactful strategies? What can individuals and healthcare systems do to really get proactive about managing this risk in different settings in the hospital, after surgery, during travel, or just in daily life? How can this knowledge spur better, more personalized risk assessment and prevention for everyone?